monthly session of our sub-working group, in this case 2.1 of the Global Coalition to Address Synthetic Drug Threats. This is the December session, December 13th, the first day out of 2 for the East group, and then we will move on to the West group as well. I have some administrative announcements I would like to start off with, and then we will begin our session. The first administrative announcement relates to a synthetic drug resolution. The United States is sponsoring a synthetic drugs-focused resolution in the UN General Assembly plenary with the goal of adoption by consensus by all 193 UN member states, taking place next Monday, December 18th in New York City. The United States introduced this resolution to highlight emerging global issues related to synthetic drugs and to urge widespread and unified support to address their associated public health and security challenges. This resolution aligns with U.S. efforts to enhance international cooperation on this urgent issue through the Global Coalition and ongoing efforts in the UN Commission on Narcotic Drugs. We urge your governments to demonstrate strong support for this effort to further elevate synthetic drugs as an urgent international issue priority by co-sponsoring this text and also by voting in favor of this issue should it come to a vote. So that is the first point. Second, I want to discuss civil society engagement. You may all recall that in the July 2023 Ministerial Declaration on Accelerating and Strengthening the Global Response to Synthetic Drugs, as we first started the coalition, and that was the sort of inaugural declaration. The participating governments at that time expressed their commitment to take into account input from civil society and coalition objectives. Now, you will recall that we took the decision through consensus based on feedback from coalition members that these meetings that we are having will only include governments and international organizations. Therefore, we've contemplated how best to incorporate civil society in our work. And the thought that we've come up with and shared with our co-chairs is to establish the following mechanism to solicit civil society input. We're going to post this information over the coming days on the coalition website, which, by the way, is hyperlinked there on the screen. First, we are going to establish national dialogues for coalition governments. So between January and February, we are encouraging governments to bring together their own civil society organizations, their national ones, and to reflect on the topics of the coalition and solicit feedback. And the United States is going to lead by example here, and our White House Office of National Drug Control Policy will be hosting a meeting of U.S. civil society organizations on the 27th of January to obtain feedback from these organizations, and we'll be posting a summary on our coalition website, and we'll encourage other governments to do the same and to provide us a summary that we can post to showcase that collaboration with civil society. Separate from that, a second opportunity will be a global civil society forum that will be held virtually by the Vienna NGO Committee, also at the end of January, where we will have, very much like the ministerial, 2 to 3 minute statements from civil society organizations from all over the world, and that will be a multi-hour event where we also would invite governments to participate and listen to the voices of civil society. Third, we are looking for an exchange of experiences on the coalition website. So we will be encouraging civil society organizations to provide us video recordings of their experiences and the work that they've done and what the recommendations are for sort of addressing and improving some of these responses to synthetic drugs. Fourth, we will be looking at recommendations from civil society organizations for the coalition website. We are eager and interested to learn about sort of what their thoughts and recommendations are that we can post for governments to observe and look at. And finally, we are looking at input from civil society organizations on achievements that they have made, and also share that on the coalition website during the months of April and July. So you see that there's a broad sort of list of opportunities to engage civil society, not just to hear from them, but to meaningfully reflect on their recommendations and hopefully to inspire governments to take action, to engage, to connect with the organizations and to foster that collaboration between governments and the civil society. Finally, I'll mention that at the discretion of co-chairs, we would also consider having civil society representatives perhaps be invited to present to specific sub-working group meetings. We will share that information, and you can develop individual links or special links for specific meetings if our co-chairs recommend to have civil society engagements. I recognize this may be more relevant for some of the sub-working groups than others, but in any case, we want to make this opportunity available to the co-chairs as well. Now, I want to share with everyone, once again, to please consult with our Global Coalition website. It's globalcoalition.us. We will be looking at translating professionally the text versus a Google sort of plugin. So we're looking at preparing for that, for the static content on the website. But you can visit it now, and you will see that the upcoming agendas for future months will be posted in that green bar just below the description. So you can always be up to date in terms of the latest agenda. When we know it, you will know it. We'll have it up there, and we'll try to keep that updated. And you can also see, as I've said before, past recordings for past sessions that you may have missed. Please find those there as well. Now I'm going to just very quickly conclude by sharing the agenda for today. With apologies, our co-chair for the East, Dr. Heti Widya-Stuti, is unable to join us. So we have as a stand-in our guest co-chairs, who you will know and recognize from past sessions, Bill McGlynn, Senior Counter-Narcotics Advisor in INL, and Sarah Finmore, Counter-Narcotics Advisor here in INL as well. They will be leading the session today and will be introducing the various speakers for whom we have recordings. So I will just conclude by mentioning that we've got quite an agenda today. We've got 3 topics that are really interesting when it comes to data sharing and data collection, and that relates to the WHO Assist program, which will be the first presentation. Then we'll discuss household surveys. And finally, something that I think we're all very familiar with, the ARQ, the Annual Report Questionnaire of UNODC, we will also hear about as well, and look forward to your thoughts and comments related to these options. I would like to ask the members, as you are listening to these presentations, please reflect on your countries and whether some of these initiatives might be of interest in terms of areas where you might like to work or strengthen or discuss in terms of how do we make these different products better. I know that there are forums to discuss issues like the ARQ. We have meetings at UNODC, very sort of complex meetings to discuss these issues, but this is also an opportunity to think of outside of the box, or perhaps to rehash some of the items that we may have mentioned before in other forums, and just want to bring to the attention as sort of continuing opportunities, concerns, challenges from the member states. So with that, I'm going to turn it over to Bill and to Sarah. Thank you both for stepping in today.
Thanks a lot, Brian. And I will take the first short introduction of my good friend, Dr. Goodman Sibeko, because I've seen his great work on the ASSIST program in South Africa. And without further ado, if I could ask that his presentation be shown at this time.
Greetings all, I'm Goodman Sibeko. I am Head of Division of Addiction Psychiatry at University of Cape Town and Director of the ITTC South Africa. I'm going to take you through the Web App Assist. In developing the Web App Assist, we sought to address a few challenges that we face in South Africa. So there's no current comprehensive epidemiological data for mental health and substance use in South Africa. There's also no comprehensive passive risk mapping for substance use in South Africa. As well as there's limited funding in general for human resource to immediately address these needs. I'm sure challenges that are mirrored in many of your own contexts. Current strategies to try and help us get a sense of where we are in terms of substance use challenges include limited indicators across the health sector, as well as the Sekendu intervention, which is a program of South African Medical Research Council, which gives us an indication of treatment demand data across the country. So now I'm just going to talk about why we've opted to work with the ASSIST tool as opposed to all of the other tools available for either screening or brief intervention and referral to treatment in general. As we know, the WHO ASSIST is a World Health Organization tool, and it really asks about recent substance use over the past 3 months and also assesses for lifetime use risks. Why we like it is that it's got a comprehensive list of substances that is long and includes tobacco and alcohol, and thereby removes the need to go between tools for specific substances. It then provides a specific level of risk for each substance, and has a key second part of the tool which provides information for brief intervention. This information and feedback talks about the risks and harms associated with each substance, which covers physical, medical, and psychological risks of regular substance use specific to each group of substances. What's worth noting is that high-risk screening scores are the ones that will lead to further assessment and referral to a specialized treatment provider. However, only a very small proportion of folks, only 5% really, of those using substances in the population are found to be at high risk and in need of this onward referral. The rest of the individuals can generally receive some benefit via the brief intervention provided as part of the feedback of the second part of the tool. So that's why we thought this would be a great tool to use in trying to detect levels of risk across the country while providing intervention in the intermediate term while we try to mobilize resources to provide more specialized treatment services. So the Web App Assist has been developed through funding from the Department of State INL through the Colombo Plan Drug Advisory Program. It's been developed and is hosted by University of Cape Town, and it is supported by World Health Organization. The key features of the tool is that it's anonymized, so there's no personal identifying data that is included in the general structure of the tool. This can of course be modified for specific purposes, as we've done with a couple of research projects that have been run on the platform already. A random code is generated with each screening process that allows the provider or the individual conducting the screen to later on link to that specific instance of screening. It can be used on any device. It is data light and automated. And what this does is it reduces training burden. In fact, it removes training burden because of the automation and the self-guidance of the tool. There's really no need for training. However, we do still provide some sort of introduction to the use of the tool. The screening report and intervention recommendation can then either be screenshot or emailed, following which the email entered for receipt is not stored on the system. And I'll demonstrate what this looks like in a moment. So the tool can be accessed either via the URL directly or by using these QR codes. So the main QR code will land you on the main landing page, while the direct QR codes indicated in the screen will land you on those specific pathways. And I'll demonstrate what those pathways are in a moment. So we've developed options for self-screening, for practitioner screening, and screening by special projects. What it means in terms of self-screening is that any member of the public, including you or I, are able to go in and detect our own level of risk for each specific substance. And the benefit here is the ability to self-administer, and therefore, in our view, facilitating self-efficacy and ownership of the wellness project. In terms of practitioner screening, we allow practitioners to create a profile which enables them to collect the screening instances that they accumulate over time so they can go back to them. And once logged in, they're able to then do the screening for their clients. And the value of this is that there's transferability of screening data. So if somebody goes to one site in South Africa where they receive a Web App Assist screening, one can be sure that the outcome is comparable to a screening that took place elsewhere, because we can guarantee that the process and the scoring and interpretation of the scores has been consistent. Of course, in terms of special projects, if there's a research project that comes in, or special projects such as we've had locally with the National Department of Correctional Services, we can add specific elements to the tool as required, and then the benefits are then specific to that project. Upon starting the tool, you are asked to enter the date of birth of the individual being screened. The purpose of doing this is so that the tool can auto-select the correct version of the tool. So we've coded all three versions of the tool, the adult and the child and adolescent version, with instances for both the 10 to 14-year-old group and the 15 to 17-year-old group, as questions do differ slightly to ensure age group appropriateness. As mentioned earlier, we don't collect any identifying data. However, we do collect these demographic data to give us a better understanding of the data. These demographic data are collected across both practitioner and self-assessment pathways. So this screening start page includes all of the substances per the standard WHO assist and includes a field for other in the event that the substance that needs to be analyzed is not included in the list above. So this is as per the standard WHO assist. You'll see here that in our mock case we had selected alcohol, cannabis and amphetamine as substances to assess for our mock client. So once the client indicates which substances are of concern to them, the rest of the substances fall away. So this is now the beginning of the automation process. You see here that this is the summary score after all of the assist questions have been asked, and you'll see that they are placed in the appropriate level of risk. So in terms of alcohol for this mock client, the risk was high, and this person therefore requires more intensive treatment, whereas for cannabis and amphetamine the risk would have been moderate, therefore requiring brief intervention and review down the line. The next page then shows the more detailed summary, which provides the information for the brief intervention. I mentioned earlier that the second part of the assist provides information on substance-specific risks and recommendations for onward referrals. So you see that this report is then provided in full, and the individual can then at this point take a screenshot of these findings or add an email address to send this information to themselves, and you'll see there what the email will look like when it arrives. So these emails can be stored. However, we do have alternative drawdown options that are possible. At the moment, we're also reporting this data alongside the Sibeko reports, which happen twice a year. And when we do that, we have a special drawdown. We've had drawdowns for the research projects that have run on the platform, as well as for Department of Corrections at national level. So there are alternative drawdown options which are possible for specific collaborators. In terms of how folks can access the tool, in terms of self-screening, QR codes can be placed strategically at places where public engagements take place or where members of the public might come across this. So this might be in social media, at public health engagements, in general areas where wellness might be targeted as an add-on service. In terms of practitioner screening, it's possible to have QR codes at public health facilities. It can be linked in training materials and general public health SOPs. QR code can be in healthcare provision areas or built into other electronic devices that practitioners use to do assessments and make notes on clients. It can also be strategically placed self-screening devices at public health facilities or mobile public health units. This is specifically a strategy quite preferred by some of our provincial collaborators in South Africa. At the local level, we've fully developed and integration tested the tool. The tool was launched in May by the Minister of Social Development, ensuring executive buy-in and commitment. Our dissemination strategy is well underway, with us participating in the Sibeko reports, which happen 6 monthly, as well as through other research output. We've linked the project to government priority programs to ensure sustainability and relevance of the tool. In terms of next steps, it's to further the integration with government information systems, to link with our geolocated resource directory, which will be launched before the end of December, and to facilitate broader use outside of South Africa, as the resource is really available and usable by anybody. And part of this strategy includes presenting this tool as a resource for the global coalition. So we look forward to seeing to what extent this tool can be useful to the global coalitions. So the idea really here is that with the Web App Assist plugged in across the primary healthcare value chain, that each time screening takes place opportunistically at sites which are not necessarily related to substance use, but which may be related, so public health, social sector, public health engagements, that in that way you can then passively be able to elicit the levels of risk across specific communities for substance use, without necessarily targeting substance use as your primary intervention. And so if you're able to then place this tool strategically and persistently in communities, you can then establish a passive risk map that allows you to keep a pulse or a sense of what the risk profiles are across various communities. That's really the vision behind the Web of Persist and how we hope it will become the solution for passive risk mapping in South Africa, and with applicability, of course, beyond South Africa. Thank you very much for your time. I'm certainly available to take questions.
Yes, and following this video, I believe we do have a comment first, and then we have a follow-up video as well from Goodman's team. Brian, did you want to chime in?
Yes, thank you very much, Sarah. This is a really exciting initiative that our friends in South Africa have developed, and we're very grateful for this. For those that work in the substance use field, you know how complex and long it takes to fill out this assist form, which is that screening form to see, you know, how severe the substance use is. And the fact that this has been digitized so that you can have clinicians sort of complete it, you could have individuals complete it as well. The rich type of heat maps that can be developed, where you can see which drugs are being consumed where, with what frequency and what time, could really be a tremendous help for policymakers. So as we look at sort of ways to collect data, this is one of these tools that we're thinking through WHO, developing a global program to initiate this and expand this beyond South Africa to other countries. I think this would be very helpful for public health officials to have an additional data point beyond household surveys, beyond sort of traditional data collection systems, to also have this screening tool be just one more sort of piece of information. So we encourage countries to consider whether this might be something they'd like to adopt when we get into the next phase of the coalition, which is around identifying initiatives to adopt. Thank you, Sarah.
Absolutely. We actually have a follow-up video as well from a member of Dr. Sibeko's team. Cyril, if you want to go ahead and press play on that, we can watch that next. Thank you.
Good morning, good afternoon, good night, good evening, dear colleagues, and greetings from Geneva. My name is Dmitry Krovchanko from WHO Headquarters, Alcohol, Drugs, and Addictive Behaviors Unit. And I would like to make a very short presentation about WHO package, assist package for screening brief intervention that we have in our program developed and used for many years. So just to start with, I would like to highlight what is written in the international standard for the treatment of drug use disorders, that screening and brief interventions, they play an essential role in providing support to people with drug use disorders, especially at the level of non-specialized care, helping to detect, identify cases, refer further to treatment, or providing brief intervention and guiding, helping people with self-care. So just to say that brief intervention is indeed an essential component for a health system focusing on identification, detection of cases. And in WHO for more than a decade, we have alcohol, smoking, and substance involvement screening test. You have probably heard of it. You will have it mentioned in other presentations today. So it was developed, as I said, like about 10 years ago to assist primary healthcare workers in conducting simple brief interventions. But also this tool, the guide, goes into detail, providing theoretical basis for SBIs, providing evidence for their effectiveness, and then going into details on how to use assist, how to facilitate asking questions about drug use, and also provide some recommendation on incorporating screening in routine practice. But what is most important, probably this is the main slide of my presentation, is not to forget that assist is not only a screening tool, that there is also a package for brief interventions that is linked to assist. So if somebody does assist with a client, they can further take another guide and provide brief intervention. And also there is another tool for self-help strategies for cutting down and stopping substance use, which might be useful in case if clinician, somebody doesn't have time to provide full brief intervention, they can still give guidance or helpful leaflets that will help people who use drugs to better manage and potentially improve their self-care. And then finally, this is my final slide. I would like to update you that this year we have updated the MBChB recommendations. And one of the recommendations that was updated was exactly on brief psychosocial intervention, especially for people using cannabis or stimulants, including also synthetic cannabis as stimulant. And the big change from the previous version is that the strength recommendation is not anymore conditional. So this is a rare example where we have a strong recommendation that people should be provided with screening and brief intervention. And if they're dependent, that they should have a referral for specialized treatment. But for these purposes, we have other tools such as MBChB, international standards, and other guidance. So I hope that you find this short presentation useful, and if you're interested, you would be happy to provide technical support on implementing, scaling up, screening and brief intervention for people using drugs, including synthetic drugs. Thank you for your attention.
Thank you to Dmitry from afar for sharing those different tools that are available. I now want to switch us to our next presentation from Kamran Niaz from UNODC regarding a presentation on household surveys. Thank you.
Good morning, ladies and gentlemen. My presentation will focus on some of the main challenges in measuring the extent of drug use and its health consequences, especially in the context of monitoring the use and health consequences of synthetic drugs. Drug use epidemiology helps us in identifying existing patterns of drug use. What are the types of drug use, drugs that are used in the community within different population groups, and in what ways they are being used. It also helps us in monitoring the changing patterns in use of different drugs over time, over geographical areas, as well as within certain population groups. Most importantly, through drug use epidemiology, we are able to detect new drugs that may have appeared in a certain community or within certain population groups. It also helps us in identifying how various methods of use of different drugs have evolved over time. And finally, it helps us in determining what are the health and social consequences of the use of those drugs. All of this information, when put together, then provides the reliable information to the policymakers to implement evidence-based programs in their community. What you see on the right-hand side are a list of indicators that are also termed as the key epidemiological indicators for drug use, for which there is an international consensus that these are the main indicators that can help us understand the extent of drug use and its health consequences in the community. On the left-hand side of the screen that you see the various sources for which from where you can collect this information. So again, if you look at the list of the indicators, the first indicator is drug use in the general population, which helps us measure the prevalence as well as incidence of drug use in a population. The second set of indicators help us look at understanding the extent of regular drug use or the high-risk drug use, especially among those who inject drugs as well as indulge in other risky behaviors. And then the other set of indicators is treatment demand, meaning the number of people who would have access to drug treatment services, the extent of people who have drug-related morbidity, that is, those who might be living with HIV, have hepatitis C, or are infected with tuberculosis. And finally, the last indicator is on drug-related mortality, people who die because of overdose or other causes related to their use of drugs. On the left-hand side, as I mentioned, are the sources of this information. So if you need to understand the extent of drug use in the general population, you need to do a population-based survey or a survey in school settings. If you want to estimate the extent of drug use among high-risk populations or regular drug users, you have to implement certain specific studies or assessments among these population groups that essentially rely on methods such as respondent-driven sampling. And the final set of indicators, or the information from the final set of indicators, comes from what are called the registers. And they essentially comprise the administrative data on treatment provision or information from testing services on HIV, Hep C or tuberculosis, and drug-related mortality data would come from your forensic analysis of people who would have died or would have been suspected of dying because of their drug use. In addition to the key epidemiological indicators that I mentioned, there are some other sources of information that can also help us understand the emerging drugs and trends in the patterns of use, and these are specifically useful in the context of understanding the emergence of synthetic drugs. So these sources of information include emergency room, where people may come for acute emergencies related to their use of drugs, community settings, forensic reports that may, where people may analyze certain samples of drugs that would have been collected or seized, police data, and of course, treatment data that may tell us that what are the new substances that have come or are being used in the community. Another new area of drug use epidemiology is wastewater analysis, which essentially looks at through the analysis of drug metabolites and helps us understand the consumption of drugs, or at least the quantities of drugs or different types of drugs that are used in various or in certain geographical locations. Here I'll just list down some of the challenges in implementing drug use surveys, which is one of the most common source of understanding the extent of drug use in the general population. Generally, in most countries, population-based surveys are based on probabilistic sample of the general population taken from the households, and generally it employs a large sample size. The information collected from household survey essentially relies on self-reported behavior of drug use, and generally it's considered that in most instances the information that would be collected would be underreported, or there might be underreporting of at least some substances for which there might be social stigma, or there are legal sanctions that, for instance, where if someone accepts that they use drugs, they may face legal sanctions because of their behavior, and therefore they would be reluctant in indulging such information to a person who is interviewing them, or if they are filling in a questionnaire on their drug use. One of the major challenge or limitations in drug use survey is that because it's based on sampling of the general population living in the household, it does not include marginalized populations that usually have a higher rate of drug use. One example of marginalized groups could be or not could be people who are homeless, people who sex workers. This may also include institutionalized populations, for example, people who are in prison settings, or even people who are being treated for their drug use disorders. Some of the challenges regarding understanding the extent of synthetic drugs are listed over here, and these considerations in general are not different for other types of drugs, but sometimes these are additionally challenges that we may have to look at. And in addition to some of the limitations that I listed earlier, one of the limitations in understanding the extent of drug use or the use of synthetic drugs in a general population is that often people who use drugs do not know exactly what they had been offered or had taken. And often we have a list of drugs based on our information, and that name or that category of drug may not necessarily be what the general population are familiar with. As well as, because there are new drugs coming in, especially when you look at the various synthetic drugs, if you look at the appearance of new psychoactive substances, again, the challenges is what do you really ask from people, that what substance have you used? You cannot, for instance, you ask a person, have you ever used a new psychoactive substances? Often you cannot tell them or ask them, have you ever used a synthetic cannabinoid? Because that's not the name or the substance that they would be familiar with. Also, another common example is that often people who use opioids would be using opioids that might have been laced with fentanyl or other adulterants. And therefore, if we were to look at the extent of fentanyl use in the community, we would not be able to capture that because the person using the drug, the opioid, would only know that he is using his falsified or whatever Oxycontin or heroin, and would not be able to tell if his drug that he had used had been laced or adulterated with fentanyl. So just to sum up, that what information do we need? We need to understand that what are the new drugs that are being used in the population, and matching the information that you would have from your, for instance, forensic sciences or forensic analysis to understand how people in the community can really identify with those substances and tell you that this is the substance that they had used. Similarly, you have to think that what could be the other relevant information that we need to understand that can help us answer the questions on who, what, and how, as well as what other information you would consider, including the extent of drug use. And a lot of this information has to come from your preparation for your survey instruments, and that comes from a lot of formative and qualitative research that can help you understand what are the phenomena that you need to measure and capture, and then include such kind of information in your general population survey instrument as an example. And finally, some information on what UNODC approach has been. A UNODC over the years has been supporting countries in different regions in understanding the extent and patterns of drug use in the countries. Some of the countries we have supported in the past include Pakistan. Nigeria is one example. We have helped implement surveys among youth population in Afghanistan, in Kazakhstan, in many of the countries in West and Central Africa, as well as help countries, for instance, in Central Asia in implementing or helping them estimate the extent of high-risk population. In general, what UNODC approach has been to use mixed methods and triangulation of different information to come up with a comprehensive picture of the extent of drug use in that country. So they not only rely on direct self-reported use of drugs that you would normally do in household surveys, but it also helps, tries to look at indirect methods of estimating drug use. For instance, drug use among the social network using what is commonly known as the network scale-up method, as well as helping implement high-risk drug use. So you are also able to look at the extent of drug use in the community. Those people who regularly use drugs that would generally be recruited through a respondent-driven sampling or a chain referral methodology, and there you try to estimate the extent of high-risk drug use using indirect methods. Some of them are listed that include multiplier benchmark or multiplier. That would be, in this case, the multiplier would be derived from the high-risk drug users, and the benchmark would comprise the administrative data. And so using all these sets of indicators, we are able to then estimate the extent of high-risk drug use that can then be triangulated with the information that would have been collected from self-reported use of drugs by the population in the general population survey or the household survey, as well as the indirect methods that would have come from the extent of drug use among the people that the respondents would know. So all of this, as I said, would help us triangulate the information and come up with a more comprehensive picture of drug use in the community. With this, I thank you for your time and understanding and attention, and I'll be happy to answer any questions later if you have any. Thank you very much.
And we are so appreciative and thankful for this wonderful presentation. I know we are getting close to time, but we have one more presentation on the annual report questionnaire, the ARQ, of which Hernan Epstein, one of our wonderful international organization coordinators of this sub-working group, to present, who has provided us a recording tonight. So we'll play that next. Thank you.
Good morning and afternoon, everyone. My name is Hernan Epstein, and I am a statistician at UNODC. Today, I will discuss the different challenges in data collections at the international level and how they can be potentially addressed. I will focus on the annual report questionnaire, or ARQ, an acronym you will hear a lot during this presentation, and the conclusions found here are applicable to all synthetic drugs data collections, but also to the collection of related to other types of drugs. The ARQ is an annual data collection mandated by the 3 international drug conventions, 1961, 1971, and 1988 drug conventions. Member states are mandated to submit the questionnaire to UNODC every year. This data collection has been around for over 30 years, so there is a wealth of information in a long time series at the national, regional, and global levels. After a 3-year long revision process, more recently, a revised ARQ was launched in 2021, and it was endorsed by the CND the same year. This revision represented a new structure of the questionnaire, with new issues that were incorporated and some that were removed as they were not relevant anymore. In addition, a new web-based platform for the data collection of data, the Data Exchange Platform, or DXP, was released, making it easier for countries to report. In addition to the ARQ, it is also always important to note and to remember that there are other data collections, especially at the regional level. Some examples of these are the EMCDDA, the OAS data collection, the African Union questionnaire, and the ECOWAS questionnaire. So this means that countries are often required to report to more than one international organization the same types of issues. So, regarding the new ARQ, the revised ARQ, this is organized in 15 annual modules that are collected every year. These can be seen on your screen currently and cover issues on demand, those in blue, on supply, those in green, and others also in black, such as legislative framework or the criminal justice system. In addition, there are also 12 rotating modules that are not collected annually, but periodically instead. Some are collected every 2, some every 3, and some every 5 years. And this can also be found on the screen. It is important also to note that both quantitative and qualitative data are collected, and this allows for all countries to provide relevant information, even if they don't have a strong statistical system or they don't collect certain indicators. So, what countries report on the ARQ? In blue in the map on the screen, you can see the countries that submitted the ARQ during the latest cycle, the latest complete cycle in 2022. In total, there are 125 countries that reported the ARQ in that year, which is a record, a historical record, and this is partly attributable to the easier submission process through the new DXP platform. This is an increase, as you can see on the chart, an increase from 110 in 2021, showing that countries were able to adapt quickly to the new data reporting mechanism. However, data gaps still persist in certain regions where coverage is still not good. These are, for example, Central and East Africa, the Pacific or the Caribbean, and also certain parts of Asia. So now, it is important to think about why this data may not be reported through these data collections. A first question to ask yourselves is whether the data collected are produced at the national level or not for each of the indicators collected. If data are not produced nationally, then of course they will not be available at the international level. Some reasons for this could be lack of capacity or resources for complex indicators such as drug use prevalence, or for example the lack of centralized systems that allow to harvest the base data. Often also lack of digitalization can be an issue in this context, and this is the case, where data is not available. We call it the no data production because data is not produced in this case. If data are produced at the national level, however, they may still not be reported by the countries, by the member states. If they are reported, we are in the case in green there, where data is of course available internationally. However, if they are not reported, they won't be available. This is the case of no data reporting. And reasons for this scenario could be that there is a high response burden on countries and they cannot find the time or resources to report, or they have too many other obligations to report to. Or it could also be that there is a lack of coordination and the national agencies with the relevant data are not consulted in the data collection process, or that there is a lack of capacity to understand how to report certain indicators, while the DXP is designed to provide the most user-friendly experience possible, there may be still some complexities in some of the questions or indicators, or even in the system itself. So we can now look at the two cases we mentioned before separately and explore potential solutions to address them. The case of no data production can take place, as we mentioned, because indicators are either methodologically complex or expensive to produce, or because data for producing these indicators are not properly pulled from the relevant sources. You can see now in the graph below that the annual prevalence shows a very low proportion of responding countries to the ARQ reporting it, especially in comparison to other indicators related to demand, such as people in treatment or drug-related deaths. And this is likely because this indicator is expensive and complex to produce, as it requires drug use surveys or similar statistical exercises to compile. So on the screen you can now see three potential solutions that are just some suggestions. The first one refers to manuals and methodological guidelines to provide countries with guidance on how to compile these complex indicators that we talked about. This could cover a manual on drug use surveys, guidelines for wastewater analysis for the production of consumption estimates, or, for example, methodological guidelines for complex estimates such as people with drug use disorders. On the right column, you can also see current or past UNODC initiatives that tackle or tackled some of these issues. For example, the Global Assessment Program, the GAP program, which is currently about 15 years old, so it could also be a good opportunity to update this type of program. Or a manual on drug use surveys, which Angela mentioned before in the first meeting of this working group, and this manual is currently under development. Second solution you can see on the second line could be capacity building and direct technical support on the production of indicators. So working closely and directly with countries in implementing these methodologies. Some examples of these could be regional or national level workshops on the compilation of drug-related indicators. Direct technical support also to countries relying on the expertise of international organizations, or, for example, the implementation of guidelines such as the manual on drug use surveys in countries via piloting exercises. UNODC has in the past held these types of workshops on drugs data, both nationally and regionally, and have also supported, from a technical perspective, national efforts of conducting drug use surveys, for example. This allows also to ensure that these efforts at the national level are up to international standards and are comparable with other countries. Finally, a last potential solution could be capacity building and support on establishing centralized data systems at the national level. And this is to allow the use of all or at least most of the data available in countries, which is not the case in many national contexts. Some examples of this could be sharing best practices and guidance materials on this process, or providing technical support in the establishment of such systems at the national level. Countries have approached in the past UNODC several times with these types of requests, but no international standards currently exist. UNODC has been working on a number of guidelines for statistical systems in police, criminal justice systems, etc. But this is wider than drugs, even though it's a good first step. Something more specific on drugs, or even specifically on synthetic drugs, is probably necessary. Another issue is that when countries request UNODC with this, often a first step that they haven't taken yet is to set up a list of leading indicators to compile. And in this sense, the ARQ has always been a good guide on which type of indicators could be compiled. Now we move on to the case of no data reporting. Here, this could take place because of a number of reasons as well. It may take too much time and resources for countries to report, or in the case of certain indicators, they may not be reported because the agency with the relevant information was not consulted, or because they may not know how the reporting mechanism works, or some of the questions may be unclear to the countries as well. An example you can see here on the criminal justice system indicators. You can see that for most countries, police and law enforcement agencies are involved in ARQ reporting, as they are normally focal points, while in the majority of cases, the Ministry of Justice or similar agencies are often not focal points. As you can see in the graph, data on arrest or formal contact with the police shows a much better coverage than data from the criminal justice system on prosecution and convictions. This is very likely because no proper coordination with other data providers, in this case the Ministry of Justice or whoever holds the type of data, is done when reporting the ARQ in certain countries. Again, here are a few potential solutions on how we can address some of these issues. The first one would be to streamline regional and international data collection to decrease the response burden on member states who have to report to multiple organizations. Some steps for this would be first to align focal points and context of the questionnaires and establish a system that allows for a single reporting of data by countries. The new DXP potentially would allow for such developments. And in this sense, UNODC has already done some joint analysis with the African Union on the feasibility of streamlining questionnaires and has found high overlap on the questionnaires of the different international organizations. This is especially crucial in regions with limited resources such as Africa, not to burden them with multiple data reporting. UNODC has also started discussions on this with OAS. A second potential solution would be the establishment of mechanisms for data sharing at the national level, but also amongst international organizations. An example could be the development of material to guide on the establishment of national drug observatories and to support countries in implementing this, something that OAS has mentioned in the last meeting. Also important would be to establish mechanisms for data sharing amongst international organizations. In this sense, UNODC has done this in the past in an ad hoc fashion with EMCDDA, with African Union, and with OAS. And finally, a last potential solution to this scenario could be the capacity building and support on international reporting, especially through the ARQ. The organization of regional and global workshops on data reporting is an important element, an important step, as well as meeting of focal points for data collections. This can also strengthen the network and the community of data providers and increase reporting and comparability of the data. UNODC regularly organizes both virtually and in-person workshops on data collection and reporting, and experience has shown that in-person events are notably more effective than virtual ones. And here you can see an example of this. The last year in 2022, an in-person training on the ARQ was organized in West Africa for countries of this sub-region, and as a result there was an increase from 13 to 24 countries reporting in Africa, the majority coming from this region in West Africa. And you can see this in the maps, the coverage for the 2 years, 2021 and 2022. So with this, I would like to finalize my intervention. I hope this presentation really encourages a discussion on how to address current data gaps in the global drugs data ecosystem, and that some additional initiatives and potential solutions can also be added to the list explored here, which are only just initial suggestions. Thank you very much.